Swayam Prabha. Digital India. Educated India.
Hello guys, I am Vinayak Rengan. I am a general laparoscopic surgeon and I also run a startup called Curium Life where we solve everyday problems in surgery using machine learning, artificial intelligence and deep learning. So what I essentially do is I operate on the abdomen, I operate on the thyroid, breast, but a majority of my work deals with laparoscopy. So many people call me a laparoscopic surgeon. In some countries I am called as an endoscopic surgeon. So we are going to kind of look into all these terms. What is endoscopy? What is laparoscopy? And we're kind of going to understand where this field stands with regards to image processing, machine learning, deep learning, and everything. So endoscopy is a very misunderstood term. There has been a lot of hype, a lot of misconceptions regarding endoscopy. People imagine a scary looking surgeon with sharp instruments poking holes into wherever sharp stuffs are not supposed to go, but it's not as scary. It's one of the most commonly done procedures all over the world. And the definition of endoscopy is basically using long tubes to view any hollow organ. That hollow organ can be your esophagus, stomach, your small intestine, large intestine. It can be your bronchus. Bronchus is the the bifurcation of the windpipe. It can be even visualizing inside the abdomen, what we call as the peritoneal cavity. So there are a lot of terms involved in this. A brief understanding of these terms would help you understand the entire industry and give you an overall outlook. So what we see here is a bronchoscopy. Bronchoscopy essentially involves passing a tube through your windpipe. So this bifurcates into what we call as the bronchus, and you're able to visualize the inside of your windpipe. So this is a very important modality in diagnosing and even ruling out problems such as lung cancer, early lung cancer, and also kind of removing foreign bodies. So again, like any forms of endoscopy, it can be either diagnostic or therapeutic. When I say diagnostic, it means like you're trying to diagnose or find out what the problem is. When I say therapeutic, I mean I'm trying to treat what the problem is. So bronchoscopy can also be diagnostic or therapeutic. So when I diagnose, I can just visualize what's there. Is there a problem? I can take biopsies. These biopsies will be sent to the pathologist and they will tell me whether it's cancer or whether it's something to be scared or not scared. It can be therapeutic. When I say therapeutic, I can remove foreign bodies. I can remove small growths or polyps. So what you see here is a image of a lesion at the bifurcation, near the bifurcation. So here you can see that the trachea, the windpipe is bifurcating into the right bronchi and the left bronchi. So here you see a lesion. It could be a suspicious lesion, it could be cancer, so or it could be something which we don't know, and what we are trying to do is we might take a biopsy from there and send it to the pathologist to understand what that is. Upper GI endoscopy. Upper GI endoscopy is what we traditionally understand or call as endoscopy. When I say endoscopy, what I usually mean is just upper GI endoscopy. That involves putting a tube into your foot pipe and it goes into the stomach, where I can visualize the stomach, and sometimes even early part of the small intestine. Again, it can be diagnostic or therapeutic. When I say diagnostic, you can see if there is a cancer, and when I say therapeutic, again I can remove foreign bodies. If there is, in fact, it is kind of advanced so much that if there is a small tear or a perforation was what we call, you can even close those rents through endoscopy. So endoscopy as a field has advanced extremely well, and now we are even able to go into the biliary tract, which is like the bile duct and the pancreas, to remove stones. So that's all very technical stuff inside endoscopy, and that's not something what we are going to do. Here what you see is an image is a computer vision tool as kind of segmented lesions in an endoscopy. So endoscopy, because of the huge volumes it has immense applications in the area of machine learning and supervised and unsupervised learning as well. So here what you can see is somebody has boxed the lesion in both these lesions, and you can use machine learning tools to kind of understand what these stuff are. Lower GI endoscopy is traditionally called as colonoscopy. It involves passing a tube through your anus and visualizing the large intestine. The large intestine leads into this thing, the anus, and it involves passing a tube through here, and it goes till where the small intestine starts. So it's a very technically demanding procedure, much more demanding than the traditional upper GI endoscopy. Again, it can be diagnostic or therapeutic. Diagnostic and colonoscopies are performed on a day-to-day basis. Thousands of them are performed every day in India, and all over the world it's a very common procedure. In most parts of the world it's a daycare procedure. It can be therapeutic, you can remove small polyps, you can do certain small procedures over there through coloscopy as well. Laparoscopy is essentially putting a tube inside the abdomen. That's me on the screen. So what I am trying to do is I am trying to remove the gallbladder. Gallbladder is an organ just under the liver, and right now since early 90s laparoscopy has been considered the gold standard for gallbladder surgeries. In many other fields of surgery, laparoscopy is slowly emerging as a gold standard. These days we perform a whole gamut of procedures through laparoscopy. As you can see here in this particular diagram, this is the abdomen, and you inflate the abdomen with gas, which is usually carbon dioxide, and put in a camera. This is usually a 10 mm or a 5 mm camera, and then you have working ports 2, 3, 4 depending on how you use them, and these can involve graspers, needle holders. You can suture, you can cut stuff, you can remove stuff. There are a whole host of videos available on YouTube or any other platform, so you can kind of watch them to understand what really happens in laparoscopy. There's a lot of physics and optics involved in laparoscopy. We have different types of cameras. There are 0-degree cameras, then we have 30-degree cameras, which kind of allow for greater degree of movement. There are 45-degree cameras. Each of them has their own different applications. There are energy devices which you can push through your laparoscopy. There can be electrocautery, and it's a whole different field of physics, surgical electrocautery and surgical energy devices. And these days we are using laparoscopic ultrasound as well, putting an ultrasound device through your laparoscope and trying to visualize certain cancers which cannot be visualized through CT or MRI or traditional ultrasound. So the potential for laparoscopy is immense, and right now we are doing everything through laparoscopy, a lot of stuff through laparoscopy. It requires a huge amount of skill and dedication on the part of the learner who to improve his skills in laparoscopy. And so some of the basic principles of laparoscopy is that there is obviously, so this is the abdomen. So I'm just going to take the example of a gallbladder. So here is your gallbladder. So while approaching an organ, what you essentially follow is the principle of triangulation. So if this is the gallbladder and you need to approach it, your camera should be angled in this manner in the center, and your working instrument should be like this. So this is essentially called as the baseball diamond configuration, where you kind of approach the target organ like a baseball diamond. The instruments are here and the camera port is through here. So I'm not going to delve too much into the principles of laparoscopy, but the major need for the challenge in laparoscopy is that you're not touching the organ with your hands, so you lose that tactile sensation. And for 200 years, 300 years, we have been taught that surgery is a very tactile art. You feel the organ, you touch the organ, and that is something which we kind of lose with laparoscopy. But what advantage it gives is that it provides a degree of magnification which is not possible with conventional open surgery. So there are certain advantages, there are certain disadvantages, and robotic surgery is a type of laparoscopy. In fact, what we call as laparoscopy is straight stick laparoscopy. So your instruments are like this, And robotic surgery is not artificial intelligence surgery. There is no robo operating independently and trying to solve problems. That's still not allowed anywhere in any part of the world. And I'm sure you would also not want a non-human trying to take decisions inside your abdomen as of now. I mean, at least I would not. Even though I understand a little bit of AI and surgery as well, I still am not confident enough to trust a machine. So robotic surgery is essentially a kind of laparoscopy where the principles are same as laparoscopy, except that the instrument at the end has a wrist like motion. So what we call as the degrees of freedom. So the traditional robo, the most commonly used robo is what we call as a Da Vinci robo, produced by Intuitive Surgicals, and it has 7 degrees of freedom, which allows you to kind of manipulate organs. It gives you a semi-tactile feel, and with recent advances in machine learning and artificial intelligence, the amount of haptic feedback those instruments are giving is also kind of improving. So technology is moving in the way to take minimal access surgery. I personally feel that minimal access surgery itself is a misnomer, because it's actually maximal access. The entry is small, but the access you get is quite maximal. So it's taking laparoscopic surgery towards newer frontiers. We are able to come as close to open surgery as possible, along with the advantages of open surgery such as tactile sensation. So a lot of effort is devoted into understanding the structure of organs. Are we touching the right organ? Are we cutting the right organ? So that is an area of research in which my team is also closely involved with IIT Madras in trying to implement scoring systems in laparoscopy and in endoscopy, where we try to assess surgical performance. We try to assess whether the surgeon has correctly executed a set of steps which lead into safer surgery. So the ultimate beneficiary in all these experiments is the patient, because laparoscopy has changed the way surgery is being performed all over the world. We do have patients going back home or going back to work. My own father was operated using laparoscopy, and he was back to work in about 2 to 3 days, and that would be something unimaginable 20 years ago, where we were using conventional surgery. And if you had that conventional surgery, you would be out of work for at least 20 days, 15-20 days. So the perceptions of laparoscopy and endoscopy are changing throughout the world, especially in the field of intervention. There was a time when laparoscopy was considered a surgery for the rich, advanced devices and this thing. But the fact is that laparoscopy has the potential and the need not just in the well-off population. It serves the poorest of the poor, because a rich man can afford to stay out of work for 15 days. A poor man, a daily laborer, cannot afford to stay out of work for, even if the government is providing surgeries free of cost, which is the case in India. We have a public healthcare system which is pretty good. We are performing all these surgeries in the public healthcare system. I was trained in a public healthcare system, and all these surgeries are being performed. The biggest beneficiary is the poor people, because they are able to return back to work faster, and I think that is pushing this field further. So why do I need to know about all this? Most of you guys are engineers, who are trying to get into medical imaging, medical image processing, and understanding medical data. So for the past 10 to 15 years, as AI has grown, CT and MRI have been the foundation of artificial intelligence. We have had tangible images. We have been able to extract ground truth easily in CTs and MRIs, because you are able to label the data. The data is more reliable. The data is less operator dependent, unlike endoscopy or laparoscopy, because there is a lot of operator dependence. The way I handle the camera is going to be very different from the way my other surgeon handles it. The way I place the instruments is going to be very different. I might have my own personal preferences, but that's not the case in CT or MRI, where the machine takes a scan, and only the interpretation is left to the radiologist, and that's where AI has played a major role. But over the last few years, endoscopy and laparoscopy has a kind of the amount of cases has exponentially increased as more surgeons are having access to laparoscopy and endoscopy. The previous generation of surgeons, about 10 years older than me, they never trained in laparoscopy. But when I was training at Madras Medical College, laparoscopy had become pretty standard. And when my juniors are being trained right now, they have more access to laparoscopy because the costs are decreasing as well. But there have been very few advances in the area of endoscopic imaging and a machine learning and deep learning, because these are new fields. So if you look at most of these papers are from 2017-18, and since the COVID 2020 to 22, we have seen an explosion of research in this particular field, but it's still a very nascent field and there are a lot of work to be done. So here you can see a lot of papers. So most of these papers are in 2020 or so a lot of papers are coming up. These are all clinical journals, these are not technical journals, which talk about machine learning in GI endoscopy. GI is gastrointestinal endoscopy, and how endoscopists are using machine learning and deep learning to understand these concepts. One of the major challenges which has been in adoption is that clinicians have not kind of warmed up to the idea of using artificial intelligence for diagnosis. There's still a lot of resistance among the clinicians to using artificial intelligence techniques. There's a huge perception that how can a machine understand a diagnosis or a cancer or a particular polyp better than a human, and evidence has been conclusively mounting that machine learning techniques are kind of improving and are proving to be better than clinicians in understanding endoscopy, making endoscopic diagnosis. So computer vision in endoscopy, it can be computer aided detection, which is for lesion detection, which we call as CAD-E, or computer aided diagnosis, which can be called as CAD-X, for optical biopsy and lesion characterization. There are other roles of computer vision in endoscopy, such as guidance systems. Like for example, if you are finding difficult to negotiate the scope through narrow spaces, AI can kind of help in understanding that. So we are going to discuss a clinical problem. So we are going to discuss a problem called Barrett's esophagus, or intestinal metaplasia, also called as high grade dysplasia. It's basically what you have to kind of understand here is that this is the esophagus and it kind of leads into the stomach. So the insides of these tubes are lined by cells which are called as epithelium. These can be multi-layered depending on which part of the intestine or organ we are talking about. So in patients who have a huge amount of acidity or gastroesophageal reflux disease, GERD, gastroesophageal reflux disease, what kind of happens is that the acid which is being produced in the stomach and early part of the small intestine kind of refluxes back into the esophagus. There is usually a mechanism which prevents that. There are valves, there is a sphincter which kind of there is a muscle basically which kind of contracts when the esophagus when it is in resting state, which prevents this reflux from happening. So but when these muscles or the sphincter gets sort of relaxed due to multiple reasons, whether it can be due to an excess production of acid, it can be due to a whole host of factors including genetic factors, this acid can reflux back and kind of damage the epithelium over here. So what happens is that the epithelium of the lower esophagus starts resembling the epithelium of the stomach. So this is called as intestinal metaplasia. So this can predispose to cancer. So this intestinal metaplasia is called as Barrett's esophagus, in short called as BE. This BE can progress into cancer. The type of cancer, variety of cancer is way beyond the scope of this particular discussion. So how do you know whether it is Barrett's esophagus or whether it is cancer? You look at this particular image, how do I know which part of the intestine could be cancer? So the cancer could be over here, it could be, it grows as a small thing, it could be over here, it could be over here, it could be over here, it could be over here. Honestly, looking at this particular image, I am not able to find out where this particular Barrett's esophagus could have cancer. And to understand that, they have devised something called as the Seattle protocol. Seattle protocol consists of 4 quadrant jumbo biopsies every 1 centimeter with biopsies of mucosal abnormalities. So for example, if you kind of see this is the Barrett's esophagus area, this entire demarcated area where the color change. So this kind, if you look at it under the microscope, it kind of resembles how the stomach would be inside, and this is the lower esophageal, the muscles contracting which prevents the reflux, but this muscle complex has kind of gotten loose and it's allowing the acid to come into the esophagus. I think everybody would have kind of felt that you have had that heartburn after you have had a whole plate of biryani at 1 a.m. Along with some beer or coke. I think that's what if it happens on a regular basis and you kind of tune your diet to that particular modality, it's bound to happen, and that's not very healthy, by the way. Yeah. So what the Seattle protocol kind of does is that it goes every 1 centimeter distance and takes biopsies in every 4 quadrants, here, 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 and then another 1 centimeter here, 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 here. So this is the Seattle protocol, and that has been followed for multiple years because we never have a way of determining where the cancer could be. But you look at these studies, this is as early as 2008 and 2009. Seattle protocol does not reliably predict the detection of cancer at the time of esophagectomy than a less intensive surveillance protocol. I mean, then there is this, a 2009 paper which is even more kind of striking on the face, declaration of bankruptcy for 4 quadrant biopsies in Barrett's esophagus. So is it really obsolete? Not yet, because we kind of not have started using machine learning and deep learning in a big way. So here's this paper. This is a 2017 paper, computer aided detection of early Barrett's neoplasia using volumetric laser endoscopy. This was published in a top journal in our field, gastrointestinal endoscopy. So what we use here is a type of endoscopy called as volumetric endomicroscopy, which is a kind of microscopy which is performed through the endoscope, where you get an advanced imaging which provides near microscopic resolution of the abdominal wall layers, the esophageal wall layers. So esophagus is divided into multiple layers. What you see over here what you would see on the endoscopy would be the mucosa. There is something called as a submucosa. There are multiple lymphatics, lymph channels. There are muscle coats, muscle layers, which are kind of this thing. Understanding this anatomy is very essential, and if you look at this, it kind of makes you understand what are the layers of this thing. So here is the layer closest. So you go. These are layers which are deeper, and here what you can see is the muscle layer. So basically it provides a extremely high resolution of what you see in an endoscopy. So one of the changes in malignancy would be the loss of layering and higher surface than subsurface signal intensity. If you look at this particular image, this is NDBE is non-dysplastic Barrett's esophagus. When I say non-dysplastic Barrett's esophagus, it means that Barrett's esophagus which has not kind of become cancer, and EAC is esophageal adenocarcinoma, which is the doctor speak for saying esophageal cancer. And adenocarcinoma is a type of cancer. There are multiple types of cancers, by the way. Just saying adenocarcinoma does not kind of correlate to all types of cancer. And so if you look at this particular image, you will see that the VLE images show that the esophagus is arranged in layers. There is a layer over here, there is a layer over here, there is a layer here, there is a layer here, 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 here. So these are multiple layers which you can see. If you look at this particular image, the layering is not very clearly visible. This layering is not very clearly visible, and if you look at the intensity on the surface, this is the surface. This is the surface and this is the subsurface. The difference is there, but if you look over here in this particular image, the difference in signal intensity is pretty significant. In image B, it is much more darker, the signals are higher on the surface, the difference is remarkably visible. So in this particular image, again we can say the same thing. There is a lack of layering over here, and the signal intensity on the surface is higher over here. So basically, using image processing techniques, what they did in this particular study is they analyzed those features and extracted data of these particular features, which is the presence or absence of layering and the difference in signal intensities between surface and subsurface. I will not be getting into the technical details, the papers are available, and then they use that into and fed that information into a machine learning model. So the training images were pre-processed to remove low quality images, and then the features were extracted. So they took these two features, which is the signal difference, the signal intensity difference, and the presence or absence of layering, and they fed it into a model. there was classification again, using all these models they were able to predict the presence of cancers, and that accuracy is compared to the gold standard, which is a surgeon measuring the images or extracting those features, as well as the actual gold standard is the biopsy specimens, where you are able to confirm whether there is actual cancer or not. So, these were the machine learning models used. So, the most successful models are highlighted in grey. So, SVM, support vector machine, and AdaBoost kind of proved to be very effective, and when they tested using just layering and signal intensity distribution, but when they found that they were able to combine both layering and signal decay statistics, the AUC was pretty high, and in AdaBoost and support vector machine. So, this is the area under the curve. So, experts demonstrated an area under the curve of 0.81, and when you are using both layering and signal decay, the area under the curve was 0.95, which proved that the experts were kind of significantly less effective than the machine learning models. So, the results, when the sensitivity of optimal features, which is layering and signal decay statistics, was 90% and the specificity was 93%, and when you are using layering and signal intensity distribution, it showed a sensitivity and specificity of 83 and 93 and 83 and 87% respectively. So, there are a huge number of advantages. So, what we saw was just one of the examples of how you can use artificial intelligence and DLML in understanding and helping early diagnosis. The benefits are pretty high. If you detect an esophageal adenocarcinoma earlier on, you are able to perform a surgery, you are able to avoid sometimes life threatening palliative chemotherapy, you are able to remove only that lesion and kind of escape doing an esophagectomy. An esophagectomy is a very difficult, very technically demanding and a very morbid procedure where you remove a significant part of the esophagus and sometimes the entire esophagus, create a new esophagus using your stomach or the colon, 6, 7, sometimes even 10-hour surgeries with very poor outcomes in certain cases. Of course, with advances in surgery, many of these surgeries are also being performed safely, but once the cancer kind of infiltrates into the layers, so as the staging of the cancers is kind of done in layers. So, if you can see, this is the lumen, this is what is your foot pipe, and these are the layers, and as the cancer kind of infiltrates deeper into the layers, the prognosis becomes poor and poor, because as it grows deeper, it kind of spreads into the lymphatics, it spreads into other parts of the body as well. The cancers can tend to metastasize. So, it is extremely essential that we kind of arrive at an early diagnosis. Much of the research in endoscopy has been done in Japan, which has a very effective screening program for early gastric cancer. So, the tradition in Japan is that on the 30th birthday, everybody gets an endoscopy done for diagnosis. So, much of the research has been performed in Japan for especially gastric cancer, what we call as the EGC, early gastric cancer, and there is computer assisted diagnosis for early gastric cancer diagnosis. If you have an early gastric cancer diagnosis, you can actually treat it by endoscopic mucosal resection, where you kind of go through endoscopy itself and can remove the cancer and come out. How nice that is, having a very deadly disease like gastric cancer, and you go in the morning, oh, I have gastric cancer, the surgeon kind of identifies the gastric cancer, takes a biopsy, confirms it, 3-4 days later you go in, same endoscopy, you go in the morning, come back in the evening, your cancer is cured, and that's so beautiful. Imagine if the patient comes back 3 or 4 months down the line, he has to undergo what we call as a gastrectomy, where we remove a part of the stomach, we remove a part of the small intestine as well, because the cancer usually spreads along over there. You have to remove a whole host of lymphatics in the abdomen. The surgery operating time for the D2 gastrectomy is usually at least 4 to 6 hours. It can be done laparoscopically again, but the challenges still are there. Survival rates are still hovering between 60 to 90% depending on the center, and imagine in centers where there is a 60% survival rate, it essentially means that you delay the diagnosis by 3 months and 40 out of 100 people are going to succumb to the diagnosis. The gastric cancer would have kind of spread. Many times we go into the abdomen, we find that the cancer has spread to the liver, it has spread to other parts of the intestine, it has spread inside the abdomen completely, and then we tell the patient and the attender, it's a very difficult scenario, boss, you may not make it, your your mother or father, or your, sometimes very sadly you have to tell the parents that their son is going to die of cancer within the next few months, and I think that that's completely avoidable. Early diagnosis in this particular era is possible, and it becomes kind of inexcusable if we miss diagnosis, and that's where the role of engineers, machine learning experts kind of comes into play. It can be used for cancer staging and estimation of invasion depth. Many times you put an endoscopy, you see the cancer over there, but you don't know how inside it has gone. So you have a cancer over here, you don't know how much inside it has gone into the surface. So this helps us in staging the disease. So if it has kind of reached over there, you can say that it has become a T4 lesion or sometimes a stage 4 lesion, and the patient may have a poor survival. So the entire survival of the patient depends on where the cancer is. If the cancer is over here, it's good. If the cancer is over here, it's slightly bad. If it's over here, even more bad. And if it goes over here, it becomes really bad. And it's just a matter of few millimeters. And the role of early diagnosis kind of plays a role. And even if we are not able to make an early diagnosis, understanding the depth of penetration helps us in having a meaningful discussion with the patients about their survival, and that's very important in this particular era. In the lower GI area, we can use computer-aided detection for polyp detection and identification. We can use it for the polyp characterization and classification, and you can use it for predicting mucosal inflammatory activity in inflammatory bowel disease. Inflammatory bowel disease, you might have heard of it, Crohn's disease and ulcerative colitis. These are all not cancers. These can lead to cancers in certain cases, but these are all very potentially painful condition that affects a patient's life for 15-20 years. They reduce the quality of life. I know of many doctors who kind of suffer from these lesions. We can use them for mucosal inflammatory activity prediction, and that mucosal inflammatory activity, understanding that helps us in understanding what medications to give. Some of the medications we give for ulcerative colitis and Crohn's disease also have a huge amount of side effects. So we give a lot of steroids to treat them. So understanding the exact level of inflammatory activity helps us in tapering and adjusting the dose, so that we can free the patients of the side effects of these drugs. The future, endoscopy as we know is changing rapidly. There is growing acceptance of the efficiency and reliability of artificial intelligence in GI endoscopy, and I sincerely believe that AI is the future in endoscopy and laparoscopy. In the next session, we will be discussing more about laparoscopy in detail and how we are able to use laparoscopy to make patients' lives safer and better. Thank you.
Here are the references for the presentation. Thank you so much.